So welcome to the first keynote event of our UT Pride Pop-Up Institute. For those of you who don't know, the goal of this Pop-Up Institute is to facilitate connections and conversations amongst researchers, community members, and subject matter experts to improve the health and wellness of sexual and gender diverse people here in Central Texas and beyond. We know that two heads are better than one, and many, many little Zoom heads are even better. And so what we're hoping to do is create new connections, have y'all meet each other, and have us learn together so that we can identify gaps in the research, gaps in community needs for the larger LGBTQIA population here in Central Texas and collaborate with others outside of Texas. So thank you all for participating. We're gonna use this chat for any comments, any networking, any suggestions. And then if you all have questions that you want me to bring up to Dr. Turbin during the talk or after the talk, I'm happy to facilitate and kind of moderate the questions as well. Please note that by signing up for this talk, we have automatically added you to our listserv for future Pride pop-up events during the month of October. You can easily opt out of the listserv if you would not like to receive emails, so there'll be an option to do that. This talk is going to be recorded. The chat will be recorded as well, so that people who didn't have the opportunity to attend this talk can access it, and you can access it later, but also just to be aware that it is being recorded and the chat as well. So maybe refrain from saying anything you don't want on the internet. I think that's about all. So with that, I'm going to introduce Dr. Turbin. Dr. Jack Turbin is a fellow in child and adolescent psychiatry at Stanford University School of Medicine. He received his BA in neuroscience from Harvard College, his MD and MHS degrees from Yale School of Medicine, and completed his adult psychiatry residency at MGH McLean Harvard Medical School. His research focuses on the mental health of transgender youth, and he's been cited in media outlets, including the New York Times, CNN, and the Washington Post, among others. His research has also been cited in legislative debates and amicus briefs for cases regarding the civil rights of transgender people in the United States. In addition to his research, Dr. Turbin is a freelance opinion writer with pieces about gender and sexuality featured in the New York Times, the Washington Post, and the LA Times. He's the co-editor of a textbook, Pediatric Gender Identity, Gender-affirming Care for Transgender and Gender Diverse Youth. He serves on the Communication Council for the American Psychiatric Association and the Media Committee of the American Academy of Child and Adolescent Psychiatry. So as you can tell from that impressive bio, he has a lot of information to share with us, and we're very grateful that he has given his time to this pop-up. So with that, Dr. Turbin, I'm going to hand it over to you.
Awesome. Thanks so much for letting me join you all today. I put together a talk that is going to go through a few different areas of gender-affirming care for transgender and gender diverse youth. And for this forum, it sounded like what would be most useful was to talk about exactly what do we know from the existing research and what are the big gaps and limitations of what we know. And I'm hopeful that as we go through this, it'll spark some ideas for folks to start working on their own research projects to hopefully advance the field. For my disclosures, I have textbook royalties from Springer Nature for the textbook Pediatric Gender Identity. I'm on the scientific advisory board for Panorama Global for a charity fund to support adolescent mental health during COVID-19. I've received expert witness payments from the ACLU and Coley LLP. I have a pilot research award from the American Academy of Child and Adolescent Psychiatry, which is funded with pooled funding from pharmaceutical partners, including Arbor and Pfizer. And I received freelance payments from the New York Times, the Washington Post, and the LA Times. So this was the rough overview I was thinking about. It's probably too much for 45 minutes, and I apologize if I talk really fast. But I do want to make sure we have time at the end for questions. So if we don't get through all of it, we can end early and maybe have a discussion. But I will start with just terminology and background around the mental health of transgender and gender diverse youth. And then we'll kind of go through different life stages. So we'll start with really young kids, so pre-pubertal children. And the big questions there are mostly around early social transition. And we'll talk a little bit about conversion therapy there as well. Next, we'll talk about early adolescence, when some of these youth may consider starting pubertal blockade. Then we'll talk about the data on the mental health benefits of that. Then we'll talk about gender-affirming hormones, so things like estrogen, testosterone, spironolactone, things like that, that are generally started later in adolescence. And then if we have time, we can talk about dynamic gender identities. The idea there is that in the past, people have thought of gender identity as really the static part of someone's identity, but more and more, we're learning that gender identity can evolve over time. And I think it's important that we understand that and also try not to stigmatize it, since it's something that's been stigmatized a lot in greater society. And then in the appendix, I have things that we could talk about rapid onset gender dysphoria and questions of regret of medical interventions, if anyone's interested in that. So for terminology, this is the gender bear. I find him to be very cute. I try and use it, him, them, for all of our pediatric talks. And I use the gender bear to make sure that we're talking about 4 key concepts that we'll use throughout this, which many of you are probably already aware of. But the first is sex, or sex assigned at birth. This is the determination that's made generally by a physician when a baby is born, or before the baby is born, based on ultrasound, referring to their sexual anatomy, so their internal genitalia or external genitalia, and generally is assigned by the doctor at birth as male, female, or sometimes intersex, or having a difference of sexual development. This is, of course, very different from gender identity. Gender identity is one psychological sense of their own gender, male, female, or otherwise. This is different from gender expression. So gender expression is the way one presents themselves to the world in some sort of gendered way. So, and it's very based on societal structures. So I have short hair. That's often considered a male gender expression in our culture in the United States. If I were wearing a dress, that's generally considered a more feminine gender expression in the US. And then the 4th concept is attraction, romantic attraction or sexual attraction. And that, of course, refers to the people that you're romantically or sexually attracted to. One thing you'll notice in the literature is that the reference point for attraction is not always described correctly. So within the transgender and gender diverse community, you generally use one's gender identity as the reference point for their sexual orientation. So if I'm a transgender man who's attracted to other men, I would most likely identify as gay. But you will see sometimes when you're going through the literature that will get reversed. But for this talk, I will always use the person's gender identity as the reference point in describing their sexual orientation or romantic attraction. Sometimes it's helpful to go through a quiz. So I make these little gender bread cookies. The colors don't mean anything, but just a reminder, on the right side of the screen, you can see that the one that goes like this is the masculine symbol. The one that goes like this is the feminine symbol. Would somebody be able to describe this cookie for me?
Feel free to unmute yourself and respond, or respond in the chat.
I can go. So from what we just talked about, the sex of this example is male, and gender identity at the top in the head is woman, and then attraction is towards men, I think.
Yeah, how would you put all of that together?
Basically a transgender woman who is attracted to men.
Yeah, or a straight transgender woman. That's perfect. Does someone else want to take on this cookie? I can't see the chat, but I'm guessing it's booming with responses.
It is. Amber says straight cis man.
Yep, perfect.
Joel says,
So
yep,
sex assigned
straight
at birth
cis
is
man.
male, identifies as male, attracted to women. So this is a straight cisgender male. And then this is more what we tend to see among kids. So could somebody describe this cookie for me?
Okay, I'll go. So it looks like a female assigned at birth, right? Attracted to pretty much everything. And then in their head, either, gender neutral or non-binary, right?
Yeah,
Really well.
exactly. So the point of this cookie is just to highlight a phenomenon that we've seen. Particularly for clinicians may have seen this, that in the past, generally the kinds of kids and adults who came to gender clinics were generally very binary in their gender identity. But as there's been more acceptance of trans identities and non-binary identities, we're seeing more and more kids who are not transgender in a very binary fashion, but may fall somewhere along continuum of non-binary, or may not have figured it out yet, or may be questioning it yet. And so it's important to know that there are a lot of kids like this, and that's fine. And we just explore it with them and don't stigmatize it. And then also pointing out that sexual orientation can have the same non-binary nature of being bisexual, or some people will use queer to describe their sexual orientation, etc. So just to highlight what we know about psychiatric morbidity from trans and gender diverse kids, there are very high rates of bullying, around 80% in most studies. The rates of having a mood disorder, so like major depressive disorder, generally is what's most common, is somewhere between 12% and 64%, depending on the age and the population you're looking at. Anxiety disorders, it's around 20 to 50%. And there are very high rates of suicide attempts, which I'm sure people have heard of before. This is a graph I pulled from a review that I wrote with Diane Ehrensaft, where each dot is a different study. So this is not a longitudinal study, but it's just to give you a rough sense of what the rates of suicide attempt history look like. And you can see that it seems that as trans kids get older into young adulthood and beyond, that their odds of having attempted suicide becomes much higher. And that generally there's a huge disparity between trans and gender diverse people and the general population for suicide attempts. I also like to use this study for background. This is a clinical perspectives that we published in the Journal of the American Academy of Child and Adolescent Psychiatry. And we just took a big group of transgender adolescents and asked them what they wanted their doctors to know. And these were the big things. And since there are probably a lot of doctors on here, research, and maybe also clinicians, I'd like to share it with you. So one is that they want people to know that gender and sexuality are totally different things, like we talked about earlier. And they really don't want people to presume one based on the other. So for instance, a lot of transgender and gender diverse kids don't identify as straight in their affirmed gender or in their gender identity. They want to point out that talking to strangers about this is uncomfortable, particularly because a lot of them have had negative experiences in the past where people have been rejecting or unaccepting of what they were telling them. They want their doctors to know that non-binary people exist and to not think that they're just confused for being non-binary, but that non-binary is a valid identity and not necessarily just somewhere on the path towards having a binary identity. They point out that names, pronouns, and gender markers are very important. This is a place where a lot of people get caught up because pronouns can be hard, right, to remember to use correctly. But it's important to know why they're such a big deal. So what the kids say is that when they hear you use the wrong pronoun, especially if they don't know you well, that brings up a lot of the feelings of past people who have rejected them for their gender identity, and they start projecting those dynamics onto you. So all of a sudden you become their parent who kicks them out of the house, or their middle school bully who harasses them for being transgender. So if you mess up the pronoun, what they said is it's helpful to just say, I'm so sorry I messed that up. I'm really trying to get this right. I'm not at all trying to invalidate your experience. I'm on your team. I accept you for your gender identity. I'm going to work harder and make sure I get the pronouns right. For the sake of time, I'll let you just read through the other ones. But two other big ones to point out were if I'm anxious or depressed, it's likely not because I have issues with my gender identity, but because everyone else does. So these kids were pointing out that yes, body dysphoria is an important thing for them, but a lot of times what's much more difficult is the fact that the people around them are not being accepting and are making their experience even harder. And letting them know that you're on their team. So they recognize that mistakes are going to be made, but at the end of the day, what they want to know is that you accept them and you're going to support them. So for the first controversy, if you will, I'm going to talk about pre-pubertal children. This is a tricky subject. Generally in the US, especially in the past few years, there's been a pretty broad consensus that early social transition for a pre-pubertal child is appropriate, which I agree with, and that conversion therapy is wrong, which I also agree with. So I'm going to talk about some people who I don't agree with and some theories that I don't agree with. And the reason I do so is that I think it's important to know that these are still really prominent people in the field who've done a lot of great research, and their ideas are around and not kind of in the distant dark past. These are ideas that have been spoken about as recently as the past few years. So I think it's important that we talk about them and really know exactly what we know from the research and what we don't in terms of taking care of these very young children. So three main approaches have been described for prepubertal kids. The first was popularized in Toronto by Ken Zucker, and that is the living in your own skin model. In that model, they interpret some studies, which we can talk about at the end. I don't agree with this interpretation necessarily, that most prepubertal kids who have some gender diversity will grow up to be gay and cisgender. And so their philosophy is that if they can hasten that process of making them more comfortable with their sex assigned at birth, that would be a good thing. So they will do psychotherapeutic interventions to try and promote that identification with the sex assigned at birth. And they will prohibit an early social transition, or at least tell parents that they recommend that a child not do that. On the other end of the spectrum, what's more popular in the US is the gender affirmative model popularized by Diane Ehrensaft at UCSF. And what this says is that for a kid who wants to explore their gender identity, you let them. And if they want to socially transition, you let them. And you don't do anything to try and force them one way or the other with their gender identity. And it's really something they should be allowed to explore and figure out on their own. And the clinician's job is to create a comfortable place for them to talk about this and to make sure that their environment is not hurting them, right? So focusing on some of these external factors that they might experience, like discrimination or rejection. The idea here is that if the therapist has the goal of making the kid be cisgender, then the kid's going to shut down. They're not going to want to talk to the therapist, especially if they do ultimately identify as transgender. They're going to have all this internalized shame that's going to drive anxiety and depression. And for the social transition, what they would argue is even if a kid does change their mind and they transition back, there's nothing inherently dangerous about that. What's dangerous is how people around that kid react. And so that's what we should focus on. In Amsterdam, there is an intermediate model called the watchful waiting approach. So they do not do any kind of attempts to force the children to identify as their sex assigned at birth, but they do tell parents that they recommend against a social transition until the child reaches puberty. For the same reason that they're interpreting some of these studies that we don't have time to go into as suggesting that most prepubertal children are not going to identify as transgender in adulthood. So there are two main questions that come out of these three approaches. The first one is social transition a good idea or not? And the second one is conversion therapy a good idea or not? So those are the two questions that I'm going to talk about next. So the first is early social transition. This is a very cute picture of a young transgender girl. And the question is, do you tell this child, no, you can't wear dresses, you need to express yourself as your sex assigned at birth? Or do you allow them to transition and go to school with their name and their pronouns and their style of dress, etc.? There's only a little bit of data on this. And so what this graph is a bell-shaped curve of anxiety and depression. Anywhere you see green, that's normal rates of anxiety and depression. The orange is preclinical anxiety and depression, and the red is clinical anxiety and depression. And Christina Olson at the University of Washington recruited a sample of transgender prepubertal children who had socially transitioned. I believe they were all binary in their gender identity. And she found that their mean internalizing scores, so this measure of anxiety and depression, were not really different from cisgender controls or sibling controls. They were slightly less anxious, but not even in the preclinical range. And this study was in 2017. If you look at studies from the other two clinics that tell parents to not socially transition their kids, their mean anxiety and depression scores were 61, 64 in this preclinical range. So it seems that the kids who were told not to socially transition had more anxiety and depression than those who didn't. We'll talk about the limitations of this data in a little bit, but big things to point out, right, is this is all cross-sectional. The kids are from 3 different countries, and the kids in Toronto and Amsterdam, their mental health was measured in 2003, whereas the kids in the US were measured nearly a decade later or more. The second thing I want to talk about is gender identity conversion therapy. So this is a paper that we published in JAMA Psychiatry last year. And it was the first paper to look at associations between exposure to attempts to force transgender people to be cisgender and adult mental health outcomes. It's a busy table, but what you can see is that all of these measures of suicidal ideation, both past year and lifetime, as well as past month severe psychological distress, there was a greater odds of having any of those among people who were exposed to these psychotherapeutic attempts to force them to be cisgender. We also looked at whether people had that exposure before age 10 as a rough cutoff of having pre-pubertal exposure, because all 3 of these approaches, none of them would say that once you hit adolescence, it would be appropriate to try and do these types of psychotherapeutic interventions. But really what some of them will say, mostly just in Toronto, is that it is appropriate for prepubertal children. So we looked just at people who likely would have had exposure when they were in the prepubertal phase. And you can see, again, exposure to conversion therapy was associated with past year suicidal ideation with a plan, and lifetime suicide attempts. And just to look at this graph quickly. So the bottom line is lifetime exposure. Sorry, the bottom line is exposure before age 10 to conversion therapy. The second line is lifetime exposure. And the last line is having had therapy, but the therapist didn't try and change your gender identity. And you can see that there's almost like a dose-response relationship depending on when the conversion therapy was implemented. So again, talking about limitations here, the first thing is that there have never been direct comparisons of these 3 approaches, and nobody's going to randomize kids to 3 different clinics around the world. So we don't have kind of RCT level data for this question, and we're probably never going to. Another question that has been brought up is that for the social transition question, the kids that we talked about from the 2 countries where they told the kids not to socially transition, those were clinic referred kids. So they were recruited through a gender clinic. The study in the US, they were recruited from the community. So some have argued that you would expect the kids who were recruited from the clinics to have worse mental health, right? Because they're referred to a mental health clinic. The thing to keep in mind is this isn't really a mental health clinic in the way we usually think, right? The kids weren't referred for anxiety or depression. The kids were referred because their parents were concerned about their gender-related issues. But it is an important point that we're comparing clinic referred kids to community samples. Also, all of those studies are cross-sectional. So we were just taking kids from each of those countries at one point in time. Christina Olsen is working on a longitudinal study of these prepubertal kids over time to see how their mental health may change. The reason that's important is for these socially transitioned prepubertal kids, they're doing well, but as they move into middle school and high school, it's possible they're going to be subjected to more stigma and more harassment, and that their mental health might get worse over time. Then for our conversion therapy study, that used data from the 2015 US Transgender survey, and it was also cross-sectional. So what we did was in one cross-section of transgender adults, we asked them, had you ever had a conversion therapy, and when did you have it? And we compared those who had it to those who said they had therapy, but their therapist never tried to change their gender identity. And obviously, reverse causation could be plausible. It's possible that people with worse mental health were more likely to seek out conversion therapy, or that the parents of young children were more likely to bring them to a conversion therapist. The USTS data also only looks at those who, like, quote, persist, right? So we were surveying transgender adults. And we don't have any data on this, but if conversion therapy is somehow effective and there are people who later identify as cisgender after it, they want to be in our study. So we don't have that data, which would be useful to have. Our argument at the end of the day is, even if it does work for some people, the fact that it has such a negative association with mental health outcomes for people who later identify as transgender, I think it's still unacceptable to do it. But it's definitely a data limitation. Our study also didn't look at the duration, frequency, or forcefulness of conversion therapy. So conversion therapy is pretty heterogeneous, right? It could range from aversive shock therapy to just talk therapy. And those likely have different effects on mental health, but nobody has ever studied those different types of gender identity conversion therapy. We used a really rough approximation of a prepubertal group, right? So we just took age 10 and said anyone under age 10, anyone who got their conversion therapy before age 10 had childhood exposure or prepubertal exposure to conversion therapy. But as you know, there's a wide range of when puberty starts. So it's possible that many of the people we captured, we didn't accurately determine whether or not their conversion therapy was before or after puberty started. And like we said, it would be unethical and illegal in many US states to conduct a randomized controlled prospective study of these three approaches. So that's probably not going to happen, but there are a lot of ways that people could look into these questions to make our data a little bit stronger and help us better understand the impacts of conversion therapy and the impacts of a very early social transition.
Dr. Turbin, sure. I have a question from the chat. Somebody asked, so how do you use this data to discuss the importance of allowing social transition in prepubertal kids to parents or pediatricians? Do you want to discuss that at the end, or do you have any thoughts now?
I can give kind of a brief answer. So I would say those papers from Christina Olsen showing that kids who have a social transition early are doing very well are very commonly used in clinics. And I think we just need to be really transparent about exactly what those data show. So what this data shows is that kids who socially transition when they're young, they do well and no worse than their peers, at least in the short term. And you can pull in a lot of other data from other studies that show that family rejection of one's gender identity is associated with higher rates of depression and suicidality. Peer rejection of one's gender identity is associated with higher rates of psychopathology. So all of those things together point to this general concept that when you reject someone's gender identity, they do worse. So generally we talk about all of those things, but we need to acknowledge that there probably are situations where you should be very mindful about what's going to happen after an early social transition. So you have to be careful about using these studies to make conclusions about any one kid, and you the one thing we don't know from this study is if those kids are going to do a lot worse as they go through middle school and high school, and we suspect they probably will if they're in environments that are rejecting. So at the same time that it's really important to affirm your child and not instill shame around their gender identity, you also have to be really working on the community and the schools and their environment to make sure that those risk factors aren't going to worsen their mental health. Another interesting thing from our conversion therapy study is even the people who were not exposed to conversion therapy, they still had really high rates of past year suicidality. And it's important to remember that conversion therapy has a strong association, but it doesn't explain everything. And a lot of these other factors like societal rejection, employment, discrimination, harassment from peers, legal discrimination, et cetera, are also going to have really dramatic impacts on mental health. And I just wanted to show quickly. So I think it's important to remember that this question of whether conversion therapy is good or bad, often in our academic circles, there's a pretty strong consensus that it's bad, right? The American Academy of Child and Adolescent Psychiatry says it's unethical. The American Academy of Pediatrics says it's unethical. The American Medical Association says it's unethical. And yet it's still legal in the majority of states in the US. So it is important for us to continue to collect data to be able to show objectively that this is a practice is hurting people as we continue to have these legislative debates in all of these yellow states you see that haven't made their mind up on whether or not they're going to ban it. Any other questions about prepubertal kids before we go into early adolescence?
Nope, I think we're good. One thing I'd like to note that's kind of to Joel's point, who asked that question, is that we will have a community town hall at the very end of this month where we're hoping to distill a lot of these great points from the research and help the community use them to make some of these arguments in clear and succinct ways. So we'd love for any people from the community or researchers to help with the creation of those, but we'll be in touch about that later.
Yeah, and there are, so ours was the first paper on this, but since there have been a few more, so if anyone wants to email me, I can send you additional citations if you are talking to legislators in your state about these things. So the next question is early adolescence and this consideration of pubertal blockade or pubertal suppression. We're going to get very sciencey for a second. I apologize. But I want to talk about GnRH so we can understand how these medications work. Can you see my cursor? Okay. So before puberty, the hypothalamus is releasing this hormone called GnRH at very low levels. So this is kind of concentration over time. You can see very little is being secreted. Once you get to early to mid-puberty, you start to get these little like spikes of it. And then once you're really in puberty, so mid to late puberty, there's kind of this sinusoid release of GnRH. And so this is what you need for everything else to happen. And so once you have this kind of sinusoid release, the pituitary will release LH and FSH. And then those will go to the testes or ovaries to make estrogen or testosterone, and that will start puberty. However, if you keep your GnRH concentrations tonically high, so you lose this up and down, it's just always high, everything downstream stops. And that's how pubertal suppression works. So we have these medications that are GnRH agonists. So it tricks the body into thinking that there's a constantly high level of GnRH. And when that's constantly high, the LH and FSH don't get released, so you don't get estrogen and testosterone. They can be provided a few different ways. The most common is a subcutaneous implant that's marketed to last a year. They usually last around 2 years. They can be removed if you no longer want to be on it. Alternatively, there are injections, including depot injections that are every 3 months. So one shot every 3 months. The important thing to know is that if you stop the shot or you remove the implant, endogenous puberty proceeds. So you're going to get your sinusoidal release back and you're going to undergo your endogenous puberty, so the puberty of your sex assigned at birth. And so in that sense, people describe these as reversible medications in terms of puberty. These are all of the studies that have been published about pubertal suppression. And you'll see that there aren't that many of them. And it really would be good if we had more, and particularly ones of higher quality. So the first to be published was from the group in the Netherlands. They followed 55 kids longitudinally and found that from before, when they first presented, to after pubertal suppression, they had lower rates of, their depression scores went down. No control group. The next study was in 2015, Costa et al. In the Journal of Sexual Medicine. What they did was they looked at the kids in their clinic. It was really retrospective, and they looked at kids who got pubertal suppression immediately compared to kids who, for some reason or another, it was delayed for them to get it. And so they looked at kids who had been on it versus kids who were delayed and still not on it yet. And so the kids who were not yet on it were just getting psychological support. The kids who were on it had the pubertal suppression and the psychological support. And they found that those kids who had accessed it earlier and had the pubertal suppression had better global functioning than those who were still waiting to get it. The problem there is those are probably not the same kind of kid, right? So usually when there's a delay in starting it, the doctors are concerned for some reason. It could be other co-occurring mental health problems, could be psychosocial concerns about why they haven't yet started the medication. So this is by no means like a randomized study design. We published a paper in Pediatrics this year where we used that same data. So it was a cross-sectional survey of 27,000 transgender adults. We took only those who said they ever wanted pubertal suppression in their life. Then we narrowed it down to those who could have conceivably accessed it based on when it was available to adolescents in the US. And then we compared in that group, those who got it and those who didn't. And we found that those who got it had a lower odds of suicidal ideation as adults. And so there ended up being 89 people in that study who accessed it during adolescence versus 3,400 who could have accessed it conceivably and wanted to, but didn't. Another thing that points out is just that access is a huge problem for these medications. There was another study from the Netherlands. This is the Van der Meissen 2020 study in the Journal of Adolescent Health, where they, again, looked at kids in their clinic who had gotten pubertal suppression versus kids who hadn't yet gotten it. And they found those who had gotten pubertal suppression had lower internalizing scores, which is like a composite score of anxiety and depression. And then finally, there was the study in the International Journal of Pediatric Endocrinology, where they followed, there were 50-something kids in the whole study, but only 23 of them had gotten cross-sex hormones, or sorry, had gotten pubertal suppression. And they found that for those 23 kids, before and after the intervention, their depression went down. So you can see that all of these researchers are kind of trying to get at this question from different angles. Nobody has a perfect study design. It's reassuring that every study that's been done shows that mental health improves, but there really is a need for better study designs. So perhaps like a large prospective study that looks at kids who access it versus waitlist controls, and maybe like if that could be randomized in some way. There are study designs that could work. This is another place where an RCT is probably not going to happen, just because most IRBs would not approve it. So it's going to have to be something a little bit more creative, like maybe a waitlist control prospective randomized study. Okay, yeah, so the limitations, no randomized controlled trials, those aren't going to happen. There's also a lot of heterogeneity in what's done before a child is offered, or I should say an adolescent is offered pubertal suppression. So the history of this is that pubertal suppression for transgender kids started in the Netherlands, and their protocol was that the kid had to come to their clinic and see their therapists for 6 full months before they would make a diagnosis of gender dysphoria and offer the medication. The DSM, right, says that you need to have the symptoms for 6 months. When that model was adapted to the United States at Boston Children's, they didn't have the capacity with a bunch of therapists to have all of these kids come have their therapy with them. So they outsourced the therapy to the community, and a therapist would just have to write a letter saying, I've been seeing this kid for 6 months and they've met the criteria the whole time. We think they should get pubertal suppression. More recently, some clinics have started taking, kind of change the interpretation of how you make the diagnosis. So in the past, you've had to be with the kid in therapy for 6 months to make the diagnosis. Some clinics, like Michelle Forcier's at Brown, will meet the kid once and take a comprehensive history. And if by history, they're telling you they've met criteria for gender dysphoria for 6 months, they would consider that to meet eligibility and they would offer the pubertal suppression. So these different approaches could have an impact on the type of kids who are getting the pubertal suppression and possibly the later outcomes. And I can't say I know which way it would go, right? So it's possible that the kids who come in and get the immediate diagnosis and the immediate access, they might do better, right? Because they're gonna not have to progress through puberty for 6 months, have worsening body dysphoria, and then maybe have worse mental health. On the flip side, the reason some of these clinics do really long assessment periods is that they're concerned that kids are gonna change their mind and there'll be different rates of regret. So those are open questions that I think are important for us to study. Also, most
Dr.
of
Turbin? Oh,
yeah.
I apologize. We're a couple minutes from the 1:45 mark. So I think maybe my suggestion is continue, and then we'll take questions in the chat as they come up.
I'll finish up the pubertal suppression section, and then we can talk. Many of these studies have also been in patients with binary gender identities. So non-binary kids, we don't have as much data about the impacts of pubertal suppression for them. And like we talked about, a waitlist control might be a better way to look at this, rather than like this delayed eligible group where the kids got it later for a reason, not because they were randomized to it or just on a waitlist. Okay, these I'm gonna skip, but just so you know, gender-affirming hormones exist. They're for later in adolescence. Similarly, there are not a ton of studies on their benefits. We have more coming out soon. And then
we do have a specific interest on discussing hormones. So maybe we'll let you do your presentation on that piece, and then I can take questions in the chat. So you have another 15 minutes to talk.
Sure. So gender-affirming hormones, the old Endocrine Society guidelines say that kids have to be 16 before they can access them. The new Endocrine Society guidelines say they can be started as early as 14 for clear-cut cases. So that would be like a kid who socially transitioned when they were like 5, right? And has been on a blocker for a really long time, and it's pretty clear they're not going to change their mind. You could start it earlier. The side effects about it, I'm going to skip for now. So again, not a ton of studies. It's this De Vries et al. 2014 study from the Netherlands that's the same as the pubertal suppression one. So those kids were followed from before any intervention, after pubertal suppression, and then after gender-affirming hormones and after surgery. And basically what they found is that anxiety and depression decreased with gender-affirming hormones. And by the end of the study, so in young adulthood, after these folks had had pubertal suppression, gender-affirming hormones, and surgery, their mental health was on par with the general population. That was like a big deal, surprising study, because in the past, the mental health disparities among trans folks had been so dramatic. And then, yeah, there have been a few more kind of longitudinal cohort studies that don't really have much of a control group, if any. We are just finished a similar study to our last one that we're going to publish, where we looked at the age at which gender-affirming hormones were initiated. So either 14 to 15, that's this new age group created by the new Endocrine Society guidelines. 16 to 17, those are the old guidelines, or in adulthood. And we compared it to those who desired but never accessed gender-affirming hormones. And what we found was that there was a lower odds of past year suicidal ideation among all the initiation age groups, and a lower odds of past month severe psychological distress. I suspect the reason the other findings aren't significant is that the N's are much smaller in this early and late adolescence group, where the N is larger in the adult access group. We did get to significance for past year suicidal ideation with the plan. We adjusted for multiple comparisons. That's why it's such a strict cutoff, but you can see these p-values where without adjusting for multiple comparisons, maybe it would have been significant. One interesting thing is that for the adults who accessed gender-affirming hormones in adulthood, They actually had a higher odds of past month binge drinking and lifetime illicit drug use. We've wondered if that's because people become more socially engaged after gender affirmation and that there might be societal factors that then drive some of those substance use questions. But that's an open question. I think more than anything, it points to the fact that there are really high rates of substance use disorders in this population. And clinically, we need to keep that in mind. So we're supporting people. Okay, I flew through that section. If we want to do questions.
I answered one question that came up, but maybe you might have some other insights. The question is, if possible, can you discuss what medical schools are doing, if anything at all, to address gender affirming approaches to care, such as the ones you mentioned? From my knowledge, there really isn't any standardization for medical schools to teach this, and I think there's very little, but perhaps you could weigh in if you know anything about that.
Yeah, there's very little. I would say most medical schools in the country don't even have someone who'd be able to teach it because the older generation of physicians a lot of them don't know anything about gender affirming care or transgender patients at all. Especially the gender affirming interventions for youth have only been around since the 1980s. And initially they were only available in the Netherlands. So it's understandable that a lot of physicians never learned about this in medical school. Schools are trying to teach this more. I started a curriculum at Yale. I started a curriculum at Mass General Hospital. I believe at Stanford they have a curriculum, but most places do not, have very little, if any. And when we designed our curriculum at Yale, we published this in Clinical Teacher, we had an interesting finding. So we provided the medical students with didactic information on gender affirming care in the data, and then tested them before and after, and they answered, their knowledge questions improved on everything, but at the end there was a question about whether or not they thought gender affirming care was should be accessible and is an important ethical treatment, and there was no change. So the didactic information didn't necessarily change their perspective on whether or not these interventions should be available. What we later did was we had transgender youth themselves come to the classroom, which was extremely generous of them, and talk to the medical students. And we didn't do a pre and post test after that because we weren't running a study anymore. But a lot of students came up after and said that meeting someone and hearing about the interventions from them made a huge difference for them to really understand what was going on. So if you're implementing teaching, it's important to keep in mind that kind of the dry data is often not enough for people to really conceptualize these questions. And it's important to either hire transgender speaking groups who could come in and speak to the class about these things. Or if you're lucky enough to have an adolescent who wants to, I know it's really hard to expect them to do that, obviously. But it's a huge blessing for the medical students to be able to have that exposure.
I really appreciate that perspective. That's what we've seen here at the medical school here at UT as well, is that we're starting to create a curriculum. And through this pop-up institute, we've hired a community advisory board of kind of a diverse array of local gender diverse people, and have just had them actually do their first talk to some undergrad students. And it was, I think, hugely helpful to get that kind of personal experience and to have a check on the medical information, because we would have them interrupt and say, well, your explanation of that spectrum isn't quite right, and this is how we would change that to match our experience. And so I think having that is really helpful. There's another question. In Texas and other states, there are bills proposed that would block access of gender-affirming hormones to adolescents. And maybe, Dr. Turbin, you can speak to your role in advocacy. What have you found to be the best or most effective way to oppose those kinds of laws that might impact care?
Yeah, so this has been surprising, luckily. So before COVID started, I was getting kind of constant emails about these bills popping up all around the country. There's not an easy way to deal with this problem, but it's kind of a multi-pronged approach, and people, I think, are gonna, whatever works best for you on how you want to contribute for these kind of things. What I've done is I wrote an op-ed for the New York Times about why those bills were a bad idea, just to increase public knowledge around why they're a bad idea. It would be really helpful if people in individual states where these were being considered, if physicians and people with expertise in this area were writing those kind of op-eds to educate the voters in their area. So hopefully those people will reach out to their state representatives to tell them not to vote for those bills. Another thing that I did was I would take some of the bills and read them and kind of fact check them, and then write a letter explaining everything that's factually incorrect about the bills, and then adding what important data I think the legislators should know about the benefits of these interventions, and then circulate that to physicians in the state to sign on, and then you can send that kind of letter to the governor or to legislators, and that's pretty powerful to be able to say, like, 100-something doctors think this bill is a bad idea, and they pointed out all the factual inaccuracies, and like, you can't pass a bill that says things that are false. So that has been helpful. Yeah, I think those are the big things. And then I think the research is really important here, right? So I think medical students maybe not as swayed by the data all the time, but I think doing research and publishing papers that show in a convincing way with better and better methodology that these medical interventions are helpful and not harmful, that's important information for legislators to have when they're considering whether or not to ban this kind of intervention. And of course, you can point to statements from the major medical organizations. So the American Academy of Child and Adolescent Psychiatry, for instance, when those bills started circulating, issued an official statement saying that they oppose those bills.
Those are great tips. Yeah, thank you.
Another thing is I was working with the American Psychiatric Association on this. And it can be really hard. I was impressed that ACAP was able to get that statement out because it's really hard to get a statement out of a national organization because there are so many stakeholders. But some of the recommendations I got from the Government Relations and Advocacy Council of the American Psychiatric Association is that if it's a state level bill, reach out to your state level psychiatric association or pediatric association, and then maybe you can maybe get a statement from them, because usually legislators care more about people in their state versus people out of state anyway.
Thank you. That's super, super helpful. Another question that a couple people asked was, can you speak to current thinking or research around the age of onset of gender dysphoria, and this concept of late onset gender dysphoria, and how that can sometimes be dismissed as, attention seeking or not quite real gender dysphoria?
Yes, this comes up a lot. So I made appendix slides for it.
Amazing.
So that largely, there are a lot of reasons this has been popularized recently, but a lot of it started with this paper published in PLOS One that you may be alluding to, which is called Rapid Onset Gender Dysphoria in Adolescents and Young Adults, a Study of Parental Reports. I guess I just jumped straight to the limitations, but I guess I could talk about what the study did. So there are a bunch of websites. I spent a lot of time on Twitter, so that's how I know about them, that there are websites for parents who think that their children are confused about being transgender. They tend to have political leanings. So one of them is called Fourth Wave Now. That's one of the websites where this researcher recruited participants for this study. And that's a reference to fourth wave feminism, which is associated with trans exclusionary radical feminism, which is this philosophical idea that transgender women are not women and thus should be excluded from feminism and women's spaces, et cetera. And that they're like a threat to women because men are a threat to feminism. And so transgender women are a threat to feminism. So these websites are out there. I've talked to some journalists recently that there seems to be some connection maybe between some of these websites and also like legal advocacy groups in the US that are evangelical. It's a complicated network of things, but at the end of the day, this is a great lesson about research methodology. So what the study did was they put an anonymous survey monkey on these websites for parents who think that their children became transgender all of a sudden and that it was due to social media influences. And she asked them, do you think your children became transgender all of a sudden later in adolescence and that it was because of social media influences? And the parents all said yes. And then they published this paper and she coined this phrase, rapid onset gender dysphoria, and then it kind of took off in the media, particularly conservative media, saying like, look, there's this research paper that proves that there's this new diagnosis of kids who identify as transgender all of a sudden because of like internet influences and peer pressure. Of course, in psychiatry, this is not sufficient data to make a new diagnosis. So the survey only studied parents and didn't ask any of the youth. And for anyone who's worked with transgender youth, or anyone who's gay, right? Like my parents probably would have said I had rapid onset homosexuality, right? Because I hid being gay for a really long time because I was afraid of rejection. And then in college, I came out as gay. And so from their perspective, it seemed like it came out of nowhere. Same thing happens with transgender folks, that they're not going to tell their parents for a long time because they're afraid of their reactions, particularly if they have the kind of parent who's going to end up on a really radical website that's like lobbying against trans care. And so from the parents' perspective, it looks like it's all of a sudden, but it'd be really important to talk to the children themselves, the adolescents, and their doctors to ask their perspective to figure out if it really was all of a sudden. So that's all of a sudden piece. The other question is whether or not it's due to peer influences. So the parents were saying, like right around the time this happened, all of my kids' friends were LGBT all of a sudden, and they were going on websites for LGBT people. So like we think those websites are why they became transgender. It's very possible that if we interviewed the kids, they would say, like I was reaching out for support, trying to meet people who are like me. And they didn't like turn me trans, but they like supported me through this difficult thing that other people weren't going to support me through. Also, just other methodology things to think about. Be careful about using survey monkeys. You want to verify that your participants are real, particularly when you're studying controversial topics like this. So you want to be careful about recruiting from websites that have an ideology. You want to make sure participants are only completing the survey once in some way. Also, the paper compared gender diversity to psychopathology, like non-suicidal self-injury and anorexia nervosa. It's obviously not appropriate to compare like normative behaviors with psychopathology that's physically dangerous. And yeah, so we need future studies to actually interview the adolescents about this and understand, and then detransition has been the other question. So the whole implication of this study is that these kids became transgender all of a sudden due to social media influences, and they're confused and they're going to change their minds later. And so like, first of all, even if they did become transgender all of a sudden from the internet, that doesn't mean they're going to later not or regret that. So that's an important question. But it does bring up this larger question in the field of regret in detransition. I think I have a slide on that too. So here's what we know about that. So there was a study of over 6,500 transgender folks who went through the Amsterdam clinic. They looked at people who got surgery, and the way they were defined regret was anyone who got surgery and then later started taking hormones of their sex assigned at birth. So it wasn't necessarily like a regret, but there's anyone who did that, and the rates were extremely low. So for trans women, it was 0.6%. For trans men, it was 0.3%. There haven't been a lot of studies on kids who start estrogen or testosterone and then stop them. In this paper of 55 kids that we talked about earlier, none regretted hormone treatment and none of them stopped it. We've published one case study since in JAMA Pediatrics of a kid who started hormones and then stopped them. And in that case, the kid said that it was important for them actually to have the estrogen, and so they identified as female and then later identified as non-binary, didn't want estrogen anymore, stopped it, but didn't regret having been on it, and actually thought it was important for them to solidify their concept of their gender identity. And they had some things that weren't going to change, like body fat redistribution and things like that, but they had been very carefully supported through the whole process and didn't regret it. So it's just important to keep in mind that stopping treatment doesn't mean regret. But we definitely need more data, longitudinal data on kids who start estrogen and testosterone and later stop it and why that is. And then the only data we have for starting pubertal suppression is that from this study in the Netherlands of kids who started pubertal suppression, almost 2% of them did not go on to estrogen or testosterone. We don't know why. They didn't look into why. One other thing I have in here quickly is we have a paper that we're going to be submitting soon, where of the sample of 27,000 transgender people, we asked them, have you ever detransitioned? 13% of them had, right? So another thing to keep in mind is if you're meeting, so this is saying a sizable number of people who identify as transgender currently have detransitioned at some point in the past. So if you're a clinician seeing someone who's detransitioning, you need to keep in mind that that doesn't mean like they're now cisgender and like it's gonna be that way forever. This may be a temporary thing and they may later transition again or still identify as trans. And 82.5% of those who said they had detransitioned did so because of some external factor. So we did a qualitative analysis of 800 free responses, and then there were many more like quantitative multiple choice responses. But after coding all of them, about 83% of people who had detransitioned did so because of an external factor like family rejection, societal stigma, couldn't find a job, etc. So the media is going to keep latching onto this idea of detransition. But two things to remember, like a lot of the times it's because of external factors. And also, even when it's not, sometimes that's okay. Like it's okay for your gender identity to develop and change and be dynamic, and that doesn't necessarily represent some sort of psychopathology. Obviously, huge limitations for this. Oh, sorry, just some quotes. So some people said, I live in a very conservative place and was afraid for my safety, so I detransitioned. The military forced me to detransition while I was in service. School staff harassed and abused me daily for my gender expression, so I detransitioned. Of course, the problem with this study is we're only interviewing people who currently identify as transgender. So it would be useful to have longitudinal studies because if somebody detransitioned and then identified as cisgender, they wouldn't be in our study, right? So we can't like make a prevalence claim or an incidence claim from this data. And we do need longitudinal data like that. Sorry, that was a long answer, but it's a complicated question.
No, that was fantastic. And I think it gets to kind of the very beginning of your talk when you showed the gender bear with the squiggly line in the head, is that I think so often when we're first teaching this, and I myself can talk about, you know, learning about all of this and then trying to teach it, is that we really have to, it seems like, break the idea of gender being binary and sex being binary in order to fully understand things like detransitioning, that it's not an X or a Y, that it can be many things in between. And I think that's not a concept that is fully understood by most.
And it's important to keep in mind that we have like a strong academic and research history of thinking that way. So a lot of the early clinics wouldn't offer gender affirming medical interventions to kids who weren't transgender in a binary sense because the interventions were relatively new. It was the 80s. Their great fear as doctors was that they were going to start kids on hormones who would later really, really regret it. So they were afraid to do that. And now that we're getting more data and seeing how things are going, more and more people are doing that. So the literature at the same time is evolving into that understanding that a lot of our presumptions in the past about like only binary identities being valid, or that if you start hormones and then stop them, it's this horrible thing. Those are a lot of assumptions that are implicit in a lot of the literature that just recently are starting to be challenged.
Could you actually, and so I'm not seeing any new questions. Please feel free to ask a few more. I think we have maybe 5 more questions left, or I'm sorry, 5 more minutes left of your time. I wanted to ask, can you clarify what the current guidelines say for when to start kind of pre-pubertal blockers so that children don't go through puberty? You mentioned, I think before, that the age cutoff had changed recently.
So for pubertal suppression, the recommendations are to not start until puberty starts, so 10 or 2.
Got it, okay.
So both the Endocrine Society and the WPATH guidelines say that. What you're probably referencing is people in the community don't always follow the guidelines exactly.
Right. Got it, okay.
To do it a little bit earlier, but that's
the only thing right now.
Outside of guidelines.
And then you have just one clinic Friday from 10 to 2.
Sorry about that.
So
yeah, that's
the pubertal suppression before 10 or 2, before puberty starts, is out of guidelines. What I was referencing is that the age of initiation of estrogen or testosterone has moved earlier. So the old guidelines, 16, the new guidelines say you can do it as early as 14 for cases where it's pretty clear cut And the reasons that they moved it earlier were twofold. One is that if you're on blockers for too long, you fall behind on bone density, which is not obviously for osteoporosis and fracture risk. There's a great paper in pediatrics that estimated the actual fracture risk of being on pubertal suppression for a prolonged period of time, and it's extraordinarily low. So the clinical meaningfulness of falling behind is maybe not as big as many people think. We definitely need more research on that too. The other, and when you start estrogen and testosterone, the bones mineralize. The other reason is that transgender kids who have been on blockers, they notice that their peers are going through puberty. And so from a social perspective, they have said things like, it's really weird for me to be the pre-pubertal kid in my class when everyone else is like developing.
Okay.
Reason that kids often want to start the medical early.
Oh man, I have so many other questions, but I want to get to one last question maybe, and then we'll leave off. We'll cut off around 2:10, 2:15. Meg asks, can you provide a quick overview of the dynamic gender identities? Or are there a couple things you would like to mention about that?
Yeah, so we published 2 papers, one in JCAP, one in JAMA Pediatrics. And in the JCAP one, which is funny because this image is not from that paper, but in the JCAP one, we build this theoretical framework of internal and external factors. So it's not super common, but it does happen that kids' gender identities change over time, right? And they're dynamic. And that's happening more than it used to in the past, or just we're more aware of it than we were in the past. But our recommendation in those papers is that when you have a kid who's saying they want to stop some domain of gender affirmation, which could be stopping social transitions, stopping medications, like any number of things, you want to screen for a lot of things. So is this due to an external factor? Are they telling you this because they're being bullied at school? Are they telling you because their family is rejecting them? Are they telling you because they want to participate in sports and they heard that they can't participate in sports because of this? Are they telling you this because they couldn't get their ID changed, and every time they, let's say it's a young adult who's like going out with their friends, they like get misgendered every time they show their ID? And we go through a lot of different things that are important to screen for to figure out if that's what's going on, because a lot of those are modifiable. So you may be able to do work with the family to decrease a lot of that tension around the adolescent's gender expression or the young adult's gender expression or the child. You may be able to help them get an ID. You may be able to work with the school to decrease the bullying, et cetera. And then internal factors you should also ask about, because it does happen. So for some kids, it's truly like they're not sure about their gender identity. They're still trying to figure it out, or it's changing. So they are sure, but it's different than it was before. And for that reason, they want to, like, quote, detransition in some way, which, by the way, is a pejorative term to a lot of people. So because detransition has been so weaponized by the conservative media, we try not to use it, but you often end up having to use it in academic papers because the reviewers are like, what are you talking about? If you use any different term. So I apologize for using that term. But that was basically our point. And pointing out that being confused or not being sure about your gender identity or having your identity change and being dynamic is not inherently pathological. And that if that happens, it's okay. Like this kid who started the estrogen, identified as non-binary, stopped, but was happy with the process and going to college and not anxious and depressed and living a fine life.
Great, thank you. So to be mindful of your time, I think you're on inpatient service, right?
Yeah.
Gotta get back to taking care of patients. Well, thank you so much for this. In the chat, there were just so many notes that people thought this was excellent, learned a ton, absolutely fantastic. I'm reading some of the quotes. So thank you so much for this. And I'll send you and everybody here a link to the recording. And yeah, thank you so much.
Yeah, thank you for having me. And if any questions come up, feel free to email me. It's jturbin@stanford.edu. Bye. Take care.
All right, thanks everybody.